What is a hip resurfacing? And so this is a surgery I still do, although I prefer not to, and I would not put this in myself. Patients that have this know the risk and come in still asking for it. And what you can see first is a massive difference in the ball head size. And so in a hip resurfacing, we do the same steps, but we don't cut the ball off. We actually mill this ball down to a size and put a peg through the neck, and we glue this on. So then we recreate a ball. The ball is usually bigger than where you started by a size, and the risk is this can break and cause a neck fracture. Ultimately, the concern for me is the bearing. So when you look at the same acetabular component, instead of a plastic liner put in, it is metal made of cobalt and chrome, and so is this part made of cobalt and chrome. So in some patients, they can have allergies to the nickel, the cobalt or chrome, and in this is titanium, and ceramic. So the chance of metal allergy here is very slim. You can also have potentially a cement allergy. And so this hip replacement, for me, removes a lot of variables from patients' outcomes. But ultimately, the patients that want this type of surgery are told it's a more stable approach, that they're able to be more athletic. And I actually find this in my practice not to be true, and the risks don't outweigh the benefits, and that my dislocation rate is extremely low and matches that of a hip resurfacing. Whereas a hip resurfacing induces two problems that have my concern. Number one, first and foremost, is when this wears, which is a metal-on-metal bearing, it wears with metal debris. And when the body attacks that metal debris, it causes something that we call alveoli, or your lymphocytes attack it. And when that happens, they basically kill everything in the area. It kills your muscles, your tendons, your bone. When we do biopsies, there's no cellular activity. And so the patient population that asks for this are usually the 40-year-old males that want to be super active. But what I see in follow-up is that the damage that this occurs in year 10, it's not fixable. So when things are not alive, surgeons can't put that back together, and why I really prefer to still do hip replacements in those patients. Secondly, there is a hip flexor issue in which your psoas, which drapes right over this, and as you can see right here, goes right over this big head ball. And so we've learned that the increased head size, whether it be dual mobility or a resurfacing, leads to more hip flexor issues and can be a chronic problem, and why I prefer to still do the hip replacements. In a hip replacement model, you can see that the tendon, because of the smaller head size, is given a lot more room of freedom before it's rubbing on the soft tissue. And so because of the metal-on-metal concern and because of the psoas or tendonitis issues, I prefer not to do hip resurfacings. I still do them in patients that are demanding that type of technology and will go elsewhere. And there's 2 guys in the country I would recommend for that as well. But it's not a surgery I prefer. I don't think it's a benefit for a patient. If it were my hip, and this is what I tell those patients, I would much rather prefer a well-functioning total hip through an advanced anterior approach.